Respected teachers, senior colleagues, and my dear friends. At the outset, I should thank the ISA Thrissur City branch for their kind invitation, and I also congratulate the entire organizing team for their wonderful arrangements for Act 2021. A confused and agitated patient at the end of surgical procedure is not uncommon, but it is very frustrating for the perioperative physician. Though the entity is known to us for the last 100 years or so, it was the landmark article by Bedford which appeared in Lancet in 1955, known as the adverse cerebral effects of anesthesia on old people, which triggered a new interest in the topic. If you look into the incidence of the POC, postoperative cognitive dysfunction, there is a wide variation depending on the measuring tools you use. And for cardiac surgery, it can be up to 30 to 80% few weeks after surgery, which can be dropped to 10 to 60% in 3 to 6 months. And in patients over 65 years, for non-cardiac procedures, it can be up to 26% a few weeks following surgery. But definitely, it can come down to some of the patients may be self-limiting, and it can come to 10% in 3 months post-operative period. But all the reported incidents are very significant. The International Study of Postoperative Cognitive Dysfunction Group defined the problem as an objectively measured decline in cognitive function that typically persists beyond the period expected for normal recovery from the physiological and pharmacological effects of anesthesia and surgery. And the new terminology for perioperative is perioperative neurocognitive dysfunction or disorder. So, in the immediate surgery period, in the immediate anesthesia period, there will be an emergency delirium which can happen on the table or after shifting the postoperative care unit, and sometimes the cognitive dysfunction can extend in up to 24 to 72 hours, known as the postop delirium. But when it extends up to for a few weeks to months, it is known as postoperative cognitive dysfunction. So, what are the characteristics of the problem? There will be a change in the consciousness and cognition, and usually it lasts for only short period after surgery, but in few patients they can suffer permanent dysfunction. And the cluster of symptoms is very similar to Alzheimer's form of dementia. You can have, usually it is acute onset. You can have inattention, altered wake cycle, disordered thinking, memory impairment, all the problems which can be similar to Alzheimer's disease. So, what are the consequences of patient developing postoperative cognitive dysfunction? We are aware that we are likely to face more and more of geriatric patients. And it is exactly this group of patients which are the high-risk patients for developing cognitive dysfunction. So, that is the importance of this topic. And definitely, once the patient develops postoperative cognitive dysfunction, they can have increased morbidity and mortality. And definitely there will be increase in healthcare cost, and it predicts a subsequent cognitive decline in future, and definitely their contribution to the society is taken away because they develop a cognitive dysfunction. So, what are the measuring tools? There are I have mentioned only few measuring tools, but there are a number of different tools also, like Ray auditory verbal learning test, trail making test, grooved pegboard test, and mini mental state examination, which is commonly used. Basically, all these tests test the baseline cognitive function and compare it with the postoperative performance. And usually they take into account memory impairment in performance of the intellectual task. And what are the risk factors? Basically, there are patient risk factors and anesthesia and surgery related contributing factors. But now there is scientists are trying to solve out any genetic related risk factors. And they have found that apolipoprotein E4 epsilon 4 subunit carriers has got high risk of developing postoperative cognitive dysfunction, and also they have a worsened trajectory following a development of postoperative cognitive dysfunction. And geriatric population, as I mentioned, they have got they are high risk for developing cognitive dysfunction because they have a already reduced cognitive reserve and increased cerebral atherosclerosis. And any pre-existing mental health problem is a risk factor. So also the low education level, any comorbidities like frail and vascular risk factors like uncontrolled hypertension, diabetes, patients with narcotic or alcohol addiction, patients with the visual or hearing impairment. All these are high risk factors for developing cognitive impairment in the postoperative period. And social and support and quality of medical care is also very important. This is Oxford project to investigate memory impairment, memory and aging test, known as Optima test. Basically, they are recruited all geriatric populations. One as controls and the other as with the minimal cognitive impairment. So the blue line is controls and red lines is patients with the cognitive impairment. And these dotted lines in both the blue and red is a group of patients who are also geriatric definitely, but they didn't have surgery. The normal patients, the dotted lines, they did not have surgery, but when these patients, the normal cognitive impairment geriatric population had surgery, there is only a mild impairment. But when the patient has a pre-existing cognitive impairment, their fall in cognitive impairment over a time is very dramatic. That is the importance of knowing any pre-existing cognitive impairment. And coming to surgery and anesthesia risk factors, the more number of transfusions, also the hematocrit value less than 30% is all risk factors for the development. So also altered intraoperative physiology like hypotension or hypoxia, full bladder, fluid and electrolyte abnormalities, polypharmacy, and the more duration of surgery, all are risk factors for development of postoperative cognitive dysfunction. And EEG-based studies have shown that deep sedation or deep general anesthesia has got a high incidence for future development of postoperative cognitive dysfunction. Any protective role for regional anesthesia, but the evidence is lacking. But definitely, patients, it can be combined with the general anesthesia to reduce the depth of anesthesia. But when you use regional anesthesia alone with the deep sedation, they also have the same risk as the deep general anesthesia. Now, the option of using N-acetylcysteine in the intraoperative period for patients with cognitive impairment for prevention of development of postoperative cognitive dysfunction is being increasingly probed. Any choice of anesthetic agent, there's no good evidence in favor of an individual anesthetic agent. Can say which is better or not. And no consistent evidence for an IV anesthetic technique also. And short-acting anesthetic agents, better to use and better to avoid deep sedation in addition when you combine with the general anesthesia, regional anesthesia. This is an interesting meta-analysis wherein xenon was tried against different agents like propofol in patients with up to 39 to 60 years. And again, propofol in geriatric population, also desflurane and sevoflurane anesthesia. And interestingly, they found that there is no significant difference between these two, between these groups. So individual anesthetic agent doesn't matter. So what is the current evidence for the increased and decreased risk of development of postoperative cognitive dysfunction? There is a strong evidence in favor of advanced age, low educational status, previous stroke, POCD at hospital at the time of discharge, or increased risk for future development of postoperative cognitive dysfunction. There are all strong evidence And moderate evidence is development of respiratory complications, postoperative infection, longer the duration of anesthesia, and multiple surgeries in one sittings are all moderate risk factors. And definitely EEG based anesthesia and use of dexmedetomidine has got decreased evidence again, but moderate evidence, and probably the use of propofol or ketamine or NSAID in the periodontology setting may have some protective role. And what is the perceived pathogenesis? Basically, there is an imbalance between in the central nervous system cholinergic and the dopaminergic activity. There is a relative underactivity of the cholinergic system and excessive dopaminergic activity. Let us see how it happens. During surgical stress, there is a release of endotoxins and numerous cerebral emboli, and these endotoxins can release interleukins, and the endotoxins and interleukins can disrupt the intact blood-brain barrier, causing neuroinflammation. And once this widespread neuroinflammation happens, there is degradation of amyloid plaques and neurofibrillatory tangles in the CNS. And you can see an elevated levels of inflammatory mediators like chemokines, C-reactive proteins, amyloid beta, and tau deposition in the CNS. And most affected neurons are the cholinergic neurons in the basal forebrain region. And this cholinergic system is exactly required for the level of maintaining the level of consciousness, learning, and memory. So that's the all problem of developing postoperative cognitive dysfunction. So when you represent the picture, there is a surgical trauma which releases the cytokines or monocytes or macrophages, which can cross the blood-brain barrier, causing disruption in the neuroinflammation and disruption in the synaptic cleft, and ultimately developing the cognitive decline because it affects the cholinergic system more, and there is a slightly predominant action of the dopaminergic system. So what are the strategies to for the prevention? So the most important strategy is to identify the high-risk patients and discuss with the family the risk of developing postoperative cognitive dysfunction. And there is a comprehensive geriatric assessment and rehabilitation programs now going on in most of the hospitals, like correcting the anemia, nutritional status, and electrolyte imbalance, even the albumin level, everything has to be corrected in the preoperative setting itself. And geriatric populations or at-risk patients are always encouraged to have a pre-op hospital tours, and they can meet successful patients. This is already being carried out in many of the settings, like replacement surgeries, transplant surgeries, etc. And any organ-specific comorbidities has to be optimized before taking up for the procedure. And it's very important to involve the family in the postoperative care plan. And the most important thing is to adopt to ERAS protocol, Enhanced Recovery Care Bundle program, and always encourage more and more patients in the daycare procedures, which will definitely reduce the cognitive impairment in the postoperative settings. And always titrate the depth of anesthesia, if possible, with the EEG monitoring, and like a BIS-guided anesthesia, maintain adequate cerebral oxygenation. And now NERS, like in near infrared spectroscopy, is used to avoid low oxygen saturation. Always avoid hypoxia, hypotension, and hypothermia in the intraoperative settings. These are all risk factors for developing postoperative cognitive dysfunction. So attention to post-op pain management is very important. At the same time, the increased use of opioids is associated with the development of POCD. And role of regional anesthesia when combined with the general anesthesia has got a protective role. So also the use of dexmedetomidine or gabapentin in the perioperative settings. And now the acetaminophen, the role of acetaminophen is subjected to more and more research. It's a useful drug if you use it in a proper dose at proper intervals. And so also the COX-2 inhibitors, and always care for the nutritional hygiene of the patient in the post-operative period also. And always look into any correctable causes like hypoxia, pneumonia, urinary tract infection, even full bladder, electrolyte imbalances, fecal impaction, acute renal failure, or glucose imbalances, or any arrhythmias, which may also cause any cognitive impairment for the patient in the postoperative settings. And coming to the non-pharmacological impairment, always keep the patient in the calm environment. And always involve the family members, immediate family members in the postoperative period also. And the hearing aids and spectacles is the patient that has to be replaced as early as possible in the postoperative period. And reorientation to time and day, like a clock or calendar, or any familiar items in the postoperative period is very important. And as far as possible, don't use any restraint in the postoperative settings. And pharmacological interventions, please understand that it is reserved for patients who are threat to themselves or to others. And these drugs will only mask rather than treat any cognitive dysfunction. So if at all you want, you can use dexmedetomidine or haloperidol and gabapentin. Now there is an ongoing emphasis on the use of cholinesterase inhibitors. I will come to that later on. Yeah, that is coming to the future prospects. There's ongoing research on the biomarkers for neural injury and identifying the inflammatory site markers like cytokines, amyloid beta, and tau deposition in the CSF, so that you can diagnose a postoperative cognitive dysfunction and distinguish it with other cognitive disorders. And S100 beta, the beta and the neuron-specific kinolase, which are specific biomarkers for neuronal injury and possible for the development of POCD, is also probed. And a lot of research is now going on for the cholinesterase inhibitors, because we know that possible pathology is under action of predominant action of the dopaminergic system, and possibly for the deterioration in action of the cholinergic system. So role of cholinesterase inhibitors like tacrine, rivastigmine, galactamine, and donazepam. The donazepam is one agent which is being utilized for most of the researchers on the ongoing researchers especially. And memantine, N-methyl D-aspartate antagonist. Its neuroprotective role against neuronal regradation of amyloid beta is also probed. And huperazine A is another more potent cholinesterase inhibitor, and its possible action is also being subjected to a lot of research. Another agent is used, though in animal studies, is pneumodipine. Possibly they cause a reduction in calcineurin mediated hippocampal neuroptosis. That's the study as conducted in rats. Actually, whether we can extrapolate to that humans, we don't know. Any human studies I haven't noted. And acetaminophen, as I mentioned, it modulates the inflammatory response into cytokines in the plasma and hippocampus. And it has got known to have a potential neurotropic and cognitive protection role, and possibly for the development of cognitive decline in POCD patients. So also paracoxib studies, the study I have shared is conducted on 134 elderly patients. All patients received a GA for replacement surgeries, and the neuropsychological tests were done on the day pre-op, 1 week and 3 months post-op, and it was shown that the paracoxib group has significantly low incidence of postoperative cognitive dysfunction. This is an interesting study. This is the donazepam study, ongoing trial. You can see it in the clinical trial .government, and it's they have recruited 550 patients, and the study started in 2018 and is estimated to complete in 2021. There is a strong theoretical basis to hypothesize that donazepam may be useful for the patients, preventing the patients for possible cognitive impairment. That's exactly they are trying to find out, and possibly we can expect the study to come results to be announced in 2021 December or early 2022. So the option of N-acetylcysteine, I have mentioned earlier, there is a strong support for the mechanism of action for the preventive role in POCD. This study I have recruited started in 2015, and basically they are using 2,400 milligrams of NAC or placebo, and they are using in the two subset of patients at on the day of surgery, first postoperative day, second and third postoperative day of surgery, and they are trying to assess the postoperative cognitive dysfunction in each groups, and the biomarkers also they are screening, and they are looking into any reduction in the biomarkers and inflammatory oxidative stress in the group of patients who have received a NAC. So to summarize, the best, there is a strongest risk factor is advanced age and prior cognitive dysfunction for the development of POCD in the postoperative period. And the best strategy is early recognition and management of perioperative risk factors. That is the best strategy. And neuroinflammation induced by surgery in a primed brain, that means that is an aged brain or a patient with cognitive impairment, is the most accepted theory for the development of POCD. And always look into any correctable causes before labeling the patient as POCD. And the effect of specific anesthetic agent neuroinflammation in human studies still lacking. And the best strategy is to follow enhanced recovery after surgery protocol, and always better to carefully titrate the dose of anesthetic agent, especially in at-risk patients. And once the patient develops, the best option at present is supportive treatment, because a significant therapeutic agents recommendation is still missing. We hope that it will come in future or in near future at least. And validate imaging studies or biofluid markers are yet to develop for the risk stratification and monitoring. Thank you all for patiently listening.